when patients understand the value and why treatment is needed, very few times do they really kick back.
Welcome to the Digital Smile Hub, the podcast that is dedicated to making clinical dentistry simple. Join us as we decode the complexities of dental care by providing actionable insights into the diverse aspects of clinical practice, the latest trends, and the newest technologies. Whether you're a seasoned clinician or just starting out of dental school, listen in on engaging discussions, expert interviews, and a wealth of tips and tricks to enhance your clinical workflows. So turn up that volume and get ready to transform your clinical practice with the Digital Smile Hub. And now, here's your host, Dr. Tim Anderson.
What's up, everybody? Welcome back. I'm Dr. Tim Anderson. I'm so excited to have you guys here this week because we get to talk about a topic that honestly has intrigued me for really since dental school. You know, we've all been in those situations where we see cases that we're like, yeah, I should do it like this, or I should use a rubber dam, or I should isolate, or I should bond this way, or I could be more conservative. And, you know, we see all of these things in dental magazines and Instagram, social media. And it really got me thinking as a clinician, how can I be more conservative? How can I elevate the quality of dentistry that I do? And that's really how this topic of biomimetic dentistry really came up. And so when we start looking in the world of biomimetic dentistry, I mean, there's all sorts of people that we can talk about. And, you know, for me, I look at my network of individuals that I look at currently that are just doing really awesome dentistry. And that's why this week I'm super excited to introduce and excited to have Butkus. Did I say that right?
Yeah.
Butkus. All right.
Yep.
Pete, to bring him on because Pete does, like, if you guys are not following him, we'll link him on the show notes here. If you're not following him on Instagram, you guys are missing out because he does some really high quality stuff that is really elevating what it means to be a comprehensive conservative dentist that's really looking at the survivability of the tooth and really being conservative and predictable, so that way we get really good long-term outcomes. So I hope you guys are all excited. I want to welcome Pete. Pete, welcome to Clinical Dentistry Made Simple, man. Tell us a little bit about yourself.
Yeah, thanks for having me, Tim. I live in St. Paul, Minnesota. I've got a wife and 3 kids, a 6-year-old daughter and twin boys. So I'm in the trenches at work and at home. It's been kind of crazy. I went to Creighton Dental School, graduated in 2013, and I was kind of like you, Tim. I knew nothing about biomimetic dentistry, like actually coming up on 3 years ago. In fact, I took a break from Instagram for like a year because I was like, I just need to stop following dentistry like this. It's unattainable. It's ridiculous. No one does this. But then one day I just saw what Davey Alleman was doing. And at one point I messaged him and then kind of went from there, and that's how I got into biomimetic dentistry.
So what I think is really awesome for listeners to understand is that, like, you look at, one of the things I always look at when I'm talking to individuals, clinicians, like, you know, when do you graduate school? Because for me, that's like kind of like a way I can figure out, like, okay, can you relate to some of the things we did? I mean, like, crap, in school when I was there, like, I still learned about gold foils, you guys. So when I hear, you know, Pete are relatively close in age. And so, like, one of the things that I think is important for all users or all listeners to understand is that so much of what we learn along the way is it compounds. And what you learn in dental school is just the beginning. It's just the start. And so there's this huge world of dentistry, and you never know how it's going to come by. So, like, you and I both never learned about any of this in dental school. I mean, we might have seen some cases, you know, because we were...
I never did a sectional class 2 matrix for composite in dental school, no.
So how did, like, were you at a course and you saw some of this stuff, or was it just like you saw somebody online and you reached out? Like, how did you start connecting the dots here?
I just kept seeing it on Instagram, and I saw IDS, and so I researched what IDS was, but I'm...
All right, hold on. Time out.
Oh, okay.
What is IDS?
immediate dentin sealing.
And what is that?
So basically you condition and bond to the dentin and seal it up right away.
You prep the tooth and you do that. So like if you're like provisionalizing for a crown or something, like you're an indirect, you would do that right away to improve your bond strength. Correct?
Yep.
All right.
Yep, for sure.
The reason you got to remember, man, I'm really good with 3D printing and I love digital technology, but then we start getting some of this stuff, like all these bond things. I'm like, all right, I think I know what I'm talking about, but I know I'm not alone. So, we got to keep it simple for a lot of us.
Sure.
But all right, so you kind of talk to some people through Instagram. You start getting all these, ideas. Like, did you just like randomly reach out to somebody to kind of become a mentor for you?
Well, kind of, sort of. I kept seeing IDS and like I just kept seeing that around Instagram, and it takes like a decent looking prep and it's like flooding the ice rink when it's cold. It just makes it so smooth and it looks so good. But I'm not like a fearless type of person where I can just take on something. Like if I want to go tile my bathroom, I need someone to show me. I can't just hop on YouTube like some buddies of mine. But so I kept seeing it, and I finally reached out to Dave Alleman because he was doing something else too. He does these semi-direct composites which are a whole different thing that we could talk about. But and the whole copper stuff he was doing, I didn't understand what he was doing. Like you and I can look at dental accounts and most of the time we have a pretty good idea of what they're doing. I had no clue what he was doing and it fascinated me. And I reached out to him and got the course info. And to be completely honest, I was like, I can't spend that money on it now. And I waited for about a year, and I was just kind of frustrated with having sensitivity and not really trusting my ability to bond in certain scenarios. And I was just kind of like, I was about 7 years old as a dentist then. So I got the 7-year itch in my career. And I talked to my wife, and that was the first time I spent that sort of money on my own education. And it was the best investment I ever made.
That's awesome. Cause I think we all have those courses that really kind of transform and change things. And what I think's important for listeners, because we're starting to like, I want to really dive into some of the four concepts that you're doing clinically, because I think they're really important for all of us listeners to understand. And part of it is like really defining, like, we hear these terms, like you have a great Instagram account. You've got all these awesome photos of this really cool stuff. And you see it in Europe, especially, like all these really conservative, great rubber dam isolation, this great dentistry. And I kind of want to dive into a couple things. One, like to start off, like, what the hell is biomimetic dentistry? Like, what does that mean? Like when somebody says that, I think I have an idea, but what does that truly mean when people are throwing out the terms biomimetic?
It's funny because I don't think even people who practice biomimetic dentistry agree, and we all kind of get in these like little fights, and there's little sects between. It's like Christianity. There's all these different types of Christianity, at least, except what I find is the biomimetic dentists, they're so passionate and so nitpicky that they pretty much can't agree. And to me, there's like two OGs when it comes to biomimetic dentistry. Pascal Magnier, who I would think most people know who he is, and David Alleman. And those are certainly not the only heavy hitters, but in my mind, that's always been the two. And then that's like the family tree. And then from there, it kind of splits off and everyone kind of supports each other but then they kind of argue on what it means to be biomimetic. But I think some of the main tenets are utilizing adhesion to preserve pulp health and being conservative. And the whole term biomimetic is mindfully restoring the tooth in such a way that we're trying to replace what we've removed or what's been taken away from decay or cracks or whatever with materials that mimic that part of the tooth. So enamel, dentin, and then you can really kind of get into the thick of it. And, there's a difference between deep dentin, superficial dentin, like the dentin at the bottom of a proximal box, the tubules are parallel. You get a different bond strength versus the top of like superficial occlusal dentin. You're bonding to it's like if you took a bunch of straws and cut them off, that's what you're bonding to there. And just basically choosing adhesive materials that have a similar modulus of what you're bonding to.
And that's what, and I think that's like that. And I think, so what's interesting is like, a few listeners, Pete just kind of summed up, and very nonchalantly, as he went through like all these, I like that you use like these pillars or these tenets of what it means, because, I think that's one of the concepts that we kind of have this paradigm shift. Like we've got this group, we've got this huge push on mimicking nature with regards to biomimetics, of like replacing dentin with dentin-like materials, replacing enamel with enamel-like materials. And then on the flip side, we've got an industry, especially in the United States, that is so heavily focused on zirconia, and which doesn't mimic any of those materials, because it is like, and so there's not a single property from optics to fracture toughness to anything that zirconia. But at the same time, we live in a world where the bulk of new grads and the bulk of clinicians, when you look by volume, we've had this shift from like the full gold PFM world, and we've really got this group of, you're either a lithium disilicate, EMAX group, or you're a zirconia group. And I always love when I talk to clinicians, I'm like, what kind of crown do you do? And when somebody answers, I do zirconia, I do EMAX, I'm like, I just shake my head, because I'm like, I feel like we're missing the point of like, you can't be a one-trick pony. You can't have a material that does everything. And I loved, as I was kind of doing some of my homework for this podcast with regards to like, when you look at like zirconia bonding, and yes, you can zirconia bond, and I totally agree with that, and the research is there. But when you start looking at like zirconia veneers, it's like you can have a feldspathic veneer and a zirconia veneer, and guess what? The feldspathic is stronger when it's bonded to the tooth, but the zirconia is stronger when it's out of the mouth. Like, what do you want with regards to that? And so I think you bring up this interesting dichotomy with regards to like material choice, and I think the individuals that have a, I don't want to say you're focused, because I don't like identifying people as like, I'm a biomimetic dentist, I'm a holistic dentist, or I'm a GV black dentist, or I'm a this dentist. Like, I think it's important that ultimately as clinicians, we're trying to do what's best for our patients. And Pete, you made a comment that resonated really well with me, was that you talked about the vitality of the pulp with regards to your decision-making, how you're going to restore teeth. And that's, man, I think that's honestly something we as dentists, we take for granted a little bit nowadays. Talk to me a little bit about how, because, I've seen your work of how you remove decay. So like, walk us through like, when you're doing, say, just a class 2, you guys, like the most common procedure we do in dentistry, when you're walking through a class 2 that's deep towards the pulp, how your strategy is. Because I'm going to tell you, when I graduated dental school, I was taught round burr to all none ends, then hand instrument with a really sharp instrument. You scrape the crap out of the dent so you have a squeaky clean. Then you take that Explorer and you scratch around the pulp, make sure it's glassy and leathery.
You can. Yeah.
And if it doesn't bleed, you're good. And if it's red, you're okay. Just keep moving on. But then what we did is we did total etch technique, and then we bonded. Or if you were, you went to Minnesota, you placed amalgam, and we did that whole thing. But talk to us a little bit about, with regards to specifically the pillar of pulp vitality, and how your approach on pulp vitality, how you make that decision tree. So just walk us through like a deep class 2.
Sure. So first of all, I think I've always been fascinated how universal dentistry is taught. Like, that was my exact experience in dental school. And like you said, we're basically of the same vintage. But I remember one of my favorite professors, who actually my grandfather taught. So he was like, my grandfather's been dead and gone for decades. But he said, make it fine, make it shine, in relation to like, how much of the cavity do I remove? I know it's probably going to get close to the pulp. And that's what he told me. And he basically was referring to, use the round burr on high, just heat it up. Like, he didn't say that, but just be aggressive and get it out until that dentin is all burnished clean. But So for me, I love that question. It's very near and dear to my heart, because what's not near and dear to my heart is endo. I hate it. I was never that great at it, and I was good enough, but I didn't want to pursue more education in it. And if my wife needed a root canal, I wouldn't want to do it. I would send her to a specialist that I trust, and I thought that's maybe a sign that I should kind of either get better at it or give it up. So for removing decay, one of the simplest things that I was taught that you can do, and I think we're taught it in dental school, but they breeze over it really quick, is using caries removal dye or caries detection dye. And that basically just stains bright pink everywhere, or green or whatever the color is, and it stains denatured collagen. And so I use it for everything, and it's one of the cheapest dental materials you can buy. So that's like one of the first places anyone can start. It doesn't really matter if they're doing biomimetic dentistry or not.
I can't agree with that more. Like, so I'm not gonna lie. I'm gonna admit this, man. Pete, you are the reason I started using caries indicator.
Oh, I love that. That's great.
I never did it. I wasn't taught it.
I didn't either.
I was never taught. And like I started watching, like, wait a minute, why are these guys painting all this stuff on these teeth? And then I started looking at it, and what I thought was interesting was that I do a lot of laser dentistry, and I was shocked at when I thought I had removed enough decay. When I started shifting to caries indicator, I realized that my eye wasn't as good as I thought it was. But more importantly, I found out, especially with a Rumber, I was being way more aggressive than maybe I needed to be with regards to, and you can kind of talk, like, I definitely want to talk about, because talk a little bit about how you apply caries indicator, because I know it sounds like a really basic thing, but like, I kid you not, like, most of us have no idea. Like, do you scrub it on, leave it on for 2 seconds? Do you rinse it? Do you leave it on for 30 seconds? Like, how do you do it? And then talk a little bit about the transition zone with regards to your decision-making process of when you stop, because I think that's really important.
Yeah, so I think technically the instructions say you just put it on and leave it on for about 10 seconds and then rinse it off. And it still blows my mind to this day. I think it's beautiful how, like, you know, if it's a huge caries lesion, everything will be pink. But most of the time, a lot of the time, it's pretty well circumscribed. And I guess I'll back up. If it's not well circumscribed, the way I've been taught to do it is there's a Pascal Magnier and David Alleman wrote an article in 2012 about caries removal endpoints. And so they define it they put out a roadmap for what you do, but basically you add your caries dye, you start removing circumferentially, add caries dye, remove circumferentially, and basically it's a super easy article. You don't go deeper than 5 millimeters from the occlusal and 3 millimeters from the adjacent tooth, or where the contact of that tooth should be. And so if you follow that generally, and to be honest, I don't really measure, I just kind of have a good idea of when I'm getting close to the pulp, and so maybe I'm slightly higher at maybe that's a little cowboy, but
that's a total shift from the way we were taught to remove caries.
Yes.
I mean,
I was not taught to leave caries.
Oh man. And I think that's what's important for people to understand, that part of the reason of that interproximal distance is because it has to do with the bonding and the sealing of the tooth and enclosing. And that's a concept that we were not taught in dental school, like, at all. And it, ironically, it's interesting because it becomes an argument with so many people with regards to, like, you can't do this or it's going to affect the pulp. But the literature on it is very clear. Like, it's not even like, oh, it was one study that showed this. I mean, it's very clear that the whole concept infected versus affected dentin and when to stop. And I think that's an article that I'm glad you referenced, because I think it's something that it's good for us in a restorative world, that even though, yes, this is class 2, class 1 composite, talk, that I think it's really important for us to understand that we're continuing learning. And so what we learned in dental school may not even apply, even if you just graduated within 10 years. Things have totally changed, and what we were taught is one way of doing it, but there's other ways, and I think following the literature is really important. So Thank you for the Caries indicator, man. I appreciate it because I use a ton of it.
Yeah, that makes my day.
My assistants have a love-hate relationship with it, but they know it's always there now. So
yeah, no, it just, to me, it's like the most cost-effective, efficient way to just be a little bit better. You know what I mean? It makes you safer. It gives you a roadmap of where to stop, and then it when you're bonding in those situations where you have to bond over decay, it gives me that much more confidence if I have to do something that's a flat prep or like a partial coverage. So
awesome. So you remove the decay. You're using your Caries indicator. Where do you go next from the standpoint of like how you're doing this?
Are we talking like a deep or just a normal class 2?
Well, I will say a relatively deep class 2. Yeah.
So if I can matrix it with just a normal sectional matrix, I'll always try to do that because we can get into the margin elevation later. I love that. But when you're doing direct, if you have to matrix it twice, that's obviously that much harder and harder to do a good job and do hygiene checks and, make money and all those things that are important. But yeah, I'll remove the decay. I'll matrix it. I use air abrasion, so the bonding agent that I use is not a total etch, and it relies on air abrasion. So obviously, I try to air abrade before I put the matrix on, and unless I'm doing a deep margin elevation, because sometimes you can't isolate it until it's matrix. But
so when you're air abrading, are you air abrading after you've matrixed, or do you do air abrade and then matrix, or what do you prefer?
That's a good question. Yeah, so the majority of the deep margin elevation cases I do are indirect cases. That's not even pertinent to, I don't even know why I said that, but so that's when I break out the copper, and because they're so deep gingivally, and sometimes even at the bone, it's almost impossible, and I usually have the rubber dam on at that point, or maybe it's torn at that point because my burr has chewed it up, but it's almost, as any restorative dentist knows, it's like almost impossible to get it isolated to do that. Maybe I can air abrade and then it'll start bleeding again, but the copper is so thick and resilient, and I know it makes the matrix a little bit, takes the sheen away and probably takes some smoothness away, but to me it's the lesser of two evils. So if I can matrix it, if I can isolate it enough to air abrade first and then matrix, I'll always do that. But usually in a deep margin elevation situation, I'll have to matrix it to get it isolated enough so that I can know I'm sealed, and then I'm air abrading everything I'm intending to air abrade. If it's a routine class 2, I'll do the air abrasion first and then matrix.
All right, perfect. So we'll stick to like the class 2, because I do want to go down your copper and your deep margin, because that's a totally different topic that most dentists have no idea what the heck we're talking about here. I know you know it, I know it, but so with the normal class 2, so you've got rubber dam isolation, you micro braid, then you put on your sectional matrix.
Mm-hmm.
You've got this nice, you've left some of the affected dentin that's 3 millimeters away from the proximal tooth. So after it's air abraded, walk us through your bonding protocol.
So for me, like I said, I use Clear Fill SC Protect, and so that is not a self-etch adhesive, or excuse me, it is a self-etched adhesive. It's not a total etch adhesive. So basically, I don't, in like a posterior class 2 where I've etched the enamel, with my air abrasion, I don't need to etch it with phosphoric acid. You can selective etch, but then you could argue that you'd get that on the dentin. And so I use the primer and then air thin it with an air only line, because I just don't trust that air doesn't come out of the 2-in-1 thing. And then after that, you put your bond on there and try to wick up any excess. And then from there, so that's IDS. That's what that is. It's that simple. It's just using the right bonding agent the right way and putting bond over the dentin. And then what's really important, one thing that I was taught by David Alleman that he came up with, is decoupling with time. And what that does is you allow the bond that you just made to the dentin, the IDS, to have time to mature, because even when the light goes off, it's still maturing. And if you respect that and don't overload it too quickly, then you'll get a better bond strength in most scenarios to dentin than you would enamel. And that's like heresy. I realized that. I know when I heard it,
we're in the world of like
believe it.
laser cure units, and we want 1 second and 3 seconds, and like every second matters.
Yep. And so one way to help, basically you try to do 3 minimal. I try to do 5 minutes. I have a timer that I click every time I click the button to start curing the bonding agent. The first thing I do is line the whole dentin cavity floor with a certain flowable Majesty flow. I mean, there's a reason we use that type, but that doesn't matter quite as much. Basically, for that first 3 to 5 minutes, you want to not put more than 1.5 millimeters height of composite on your dentin, because if you put more than that, all the stress, the volumetric shrinkage stress it shrinks towards itself or the most strongly bonded surface. And so the weakest surface is that dentin bond at first. It'll rip away at that. I think most of us have seen that SEM, whatever you call it, picture or video where you bulk fill, cure it, and it at the bottom you just see like a white light or a white line. That's it pulling away. So if you wait that 5 minutes, do the resin coating, maybe do a hygiene exam or just be a little bit patient, then for me it gives me a ton of, then I know that my dentin bond is going to be good. And then actually in a class 2 scenario, you can use the rest of that time to start building the enamel proximal wall. So that's kind of a workaround for that. And then you're just going the whole time. Yeah.
I think that's so good for people to listen to, because we so focus, like the manufacturers try to do it, the reps try to do it, like there's this rush of like, we got to go. And honestly, when you're early in your career, you may buy into that. But I'm going to tell you right now, like redoing work takes way more time and effort than if I just wait a couple minutes to allow my bond strength to increase, to allow better isolation, to allow better etching technique, air abrasion. Like all of these little steps save time down the road. And I think that's so important. I mean, you look in the world of implant dentistry, like everybody wants to do everything quicker. Like you guys, we have to let biology do its thing. Like if you respect biology, respect anatomy, it's amazing the results you can have if you just respect that. And I get it, time is money, but we don't live in the world of seconds. I'm sorry. Like I get you might be fast, but we don't live in the world of seconds. It's worth the time to do it right the first time and not have to do it later. So I love that you talked about that, because I think that's an important factor. And honestly, but let's before I go down that road, let's go into the deep margin elevation and the difference between like what is a deep margin elevation and what techniques to use differently, specifically with the copper banding, because you're like one of the awesome people at that. And I don't even own a copper band and I don't know how to do it. So I want to know more about that personally. And so, but talk us through a little bit about that deep margin elevation, especially with respect to your indirect restorations, because I think that's one of those situations so many of us just rely on. The margin's buried, it's deep, we need retention resistance form, i.e. get zirconium, and we're going to cement it. So talk us a little bit about what is deep margin elevation, when do you do it, why do you do it, what materials you do, and then we'll kind of go from there.
Yeah, so when I took the Biomimetic Mastership 3 years ago, I was at a good point. I was taking photos. I was always using the rubber dam. I'm a horrible dentist without it. It just, like, if I have to prep 18 without a rubber dam clamp around it, I'm going to hit the tongue probably. So I had all these things, and I was a 7-year-old dentist at that point. So my hands were, I feel like, doing what I told them to do at that point. So, and I bought an air abrasion unit, and I was like, all right, I'm all in on this. And so I think that's why I margin elevate, because I just stopped cutting full coverage crowns unless I was replacing a crown. Just touching on what you said about redoing work when it's your own work, there's nothing more humbling. And I can't tell you, I'm so glad to be past that wave of work of my own that was only a couple years old, of a zirconia crown cemented with a resin modified glass ionomer. Yes, I should have used like a self-adhesive cement, but that's what I was using. And just fixing that work was so humbling. And I would fix it with these protocols and it would work. And it was just like, nothing makes you a believer like that. But yeah, when you have like a deep subgingival lesion, you can't really, if you can't isolate it, you just can't deliver it properly. Like if you can't take it all the way to the finish, what's the point of doing it? And I always try to make the first appointment the hardest because it's just going to be inherently hard anyways. So that's why I get I get the copper out. And I think I learned that from Davey and David Allman. They kind of teach it through their mastership program, but Instagram helped a lot just to see some of the people that were doing it. But yeah, basically you use your Caries dye, you isolate the lesion, or you remove the decay, and then you have to figure out how to matrix it. And Matt Najad, I think, is responsible for making those DME bands. I don't know if you've used those, Tim, but they're like, Garrison makes them. They're actually, you can get them in a it comes on a reel, REEL matrix. It's made by Garrison. Those are my go-to all the time for pre-molars, and I'll try them on molars, but usually I can tell when they don't work. They're really handy because they snug around the tooth. You can buy them for use in a Tafelmeyer too. It's just like a modified Tafelmeyer, like a greater curve that's been trimmed, sort of.
And you did that after your marginal, after your copper banding, right?
No, so that's before. So the copper is great. I love it, but it's always a last resort for me, believe it or not.
Okay.
Sometimes I'll go straight to copper, but that's only because in my mind I know the other, like a normal matrix, we're not even considering it. You know it's not going to work. That like a DME band.
This is work for people to understand, because like honestly in my head, like I use, like if it's not a sectional matrix, in my head I have one of two options. I have my type 1 Tafelmeyer and my type 2 Tafelmeyer. One, like, we call them dolly bands. We probably shouldn't have called them that in dental school, but we had those subgingival bands. But I'm like, other than that, I'm like, we were never taught anything like that, even with these deep things. So this real matrix it comes, like, you trim it yourself, but it's very similar to a Tafelmeyer, but more contoured.
So what it is essentially it's a Tafelmeyer type band put into a plastic reel that Garrison sells, and then you need a special instrument. It's like an automatrix, kind of, sort of. Okay, similar to that. Yep. Or you can buy it in just the Tafelmeyer type setup where you have your own Tafelmeyer and you put it in the Tafelmeyer. It's a more, if this is the like form of a normal Tafelmeyer band, type 1 or 2, a DME band is just more flared. And then it doesn't go above the contact. So, like, if it did that, then it would kind of bend. But so I would try that. I try a circumferential DME band, a real matrix, or just the DME band. Bill Gurgis has a trimmed version that's awesome. Pascal Monnier was one of the first to kind of show his version too. And if that doesn't work, then I put a copper.
Are you using a wedge, or are you just using the band to elevate the margin at that point?
So that's a great question. I almost never use a wedge because usually the wedge is just too high. It's past, it doesn't go down far enough, and every defect is different. So every once in a blue moon, I get super lucky and I can tuck a wedge in there, but it just doesn't usually work. It's too deep. So if I can use that circumferential matrix and get it tight enough around the tooth, that doesn't happen as much, but that's a win. I would take that. Usually what I end up doing is taking some Teflon tape and pushing it around there. I know.
Just going to ask that because Teflon might be my favorite dental material. Like,
it's awesome. It's great.
It has so many uses, from like packing, like replacing a cord technique, to matricing, to like bonding protocols, veneer. Like, oh my gosh. Like, if you guys are using Teflon in your practice, like, go to Menards, Home Depot, or whatever it is, and just buy some plumber's tape and, call it surgical Teflon, and start using it, because like that stuff will save you in so many cases. Like every implant access, if you guys are not, if so help me God, if I see another, I had to remove
it shouldn't be a thing
today that, what they're packed with?
Sponge. Oh,
no,
cotton.
No. For the first time in a very long time, I had to remove 2 crowns that were packed with rope wax.
Oh my God.
Somebody thought it'd be a good idea to wedge rope wax all in there. And I had to sit like I've seen composite, sponge, cotton, like, it is what it is. But rope wax, I'm like, you just pissed me off. I'm like, this just ruined my day. I'm like, I'm trying to like, how my that kind of is chuckling. But anyway, so that's this total sidebar. Everybody, please, PSA, place Teflon in your endo or your implant accesses from now on. Just do it. It's cheap.
And I take back what I say about Caries dye. That Teflon is the cheapest thing you could do to just get
there. You go,
a little bit better.
All right, so you're using the Real Matrix as your kind of go-to to do that initial margin elevation.
Yep.
So for listeners that can't see this or aren't looking at YouTube, we're talking about lesions that are like subgingival, so like beyond the point, like your matrix goes like at the papilla or just a little bit below the papilla. This is where it's that really deep on the cementum, on the dentin, and you're trying to get that contour. So like, even those situations where like the subgingival sectional matrix are just not gonna, like, you have to sit there and cut them forever, and even that won't adapt. That's what he's using to kind of customize a sectional matrix that's going to elevate the margin. This is not a band that he's going to use to full contour to full fill. It's just to get the margin high enough for more of an ideal situation. All right, so go on. All right, so if you can't get your Real Matrix, which I need to look up, you then will use copper. And I had never seen this until your Instagram account. So you were the first person I actually started seeing this. I'm like, what the hell is this? And I need to know more about it because it just looks so fascinating, because you were isolating cases that I thought were literally non-isolatable. Who did you learn copper banding from? 2, how do you do it? And 3, where do you get it?
So I feel like I should be endorsed by Basic Copper at this point, because it's just a website, basiccopper.com. I've referred a ton of people. I mean, it's cheap, it's easy. You buy like it's a 3 by 10 foot, but it's rolled in a spool of copper, and I just trim off a little bit at a time. I take a little piece about that big per case, and then I trim it.
Hold on, how big is that for people that are listening? Like 5 millimeters?
Thumb size.
Thumb size. All right.
Yeah.
Ish.
Just like
10 centimeters.
Yeah, just like a bigger sectional, 2 big sectionals worth, just so you, 10 centimeters worth. I just have a lot of money to waste. So, but who did I learn it from? I first saw it, I think, ever on Davey Alleman's Instagram, and I learned it from him and his dad, David. And then one of the other dentists who I think is just an amazing, just one of the best restorative dentists in the world is Brad Parrott. He's a dentist in Colorado Springs. He went to Creighton, which makes me biased because I went to Creighton. But he does some cool stuff with copper. And then I just started seeing other people doing it. Peter Farkas from Budapest does awesome stuff with copper. There's so many people now that I feel like are doing it. But
so how do you all right, you trim it. How do you adapt it? Like,
what's so forgiving? So a stainless steel matrix just crumples if you look at it wrong. Like if you put the wedge in and the wedge goes higher than the cavo surface margin, it causes it to crumple. The copper's dead soft and it's thick. Like I'm looking at the thickness of my thumbnail. The copper, and you can get different gauges, but the type that I get, and I can share with you, Tim, if you want to put in the show notes, like the gauge and specs on it, but it's really pretty thick. It's thicker than we're used to, and that's why you can't really use it as like a class 2 matrix, because then it would probably be too thick to get a contact, That thickness allows you to really burnish and put that Teflon in there to really seal the margin well. And then once the margin's sealed, sometimes I'll put like a sectional ring, like a pallet end or a V3 ring, to, even though the cavo surface margin at the box is sealed, I like to have the fins of it on the sides pushed against the tooth, and then I can burn it against the adjacent tooth.
you're trimming the copper, and then you're actually placing it and then wedging Teflon, like as if you're packing cord, but packing Teflon circularly to press that against, put the pressure. Okay.
And
I think that
of Teflon. That's the key.
and I think that
Teflon of patience. That's what I call it. That's what
so much. I loved this. My assistants are going to hate me because I'm like, all right, we're busting out the rubber dam for everything, and I'm buying copper because we've all been in those situations, and I know this because we sit there and we do our class twos, and you're like, or even when we're bonding crowns, it's like we etch, we bond, and then all of a sudden you get that little bit of bleeding. And you're like, hurry, go. And we think magically, like by going faster, that's going to fix it. But what I think's interesting about this is that this technique, if you really break it down, makes so much sense. Like it's not like reinventing the world. It's just in dentistry, we try to do a one-trick pony to fix the whole thing at once. That's why we do sectional matrices and we adapt all these principles from amalgam and all these things where I'm like, no, like, let's just build up the margin to a more ideal situation where we can truly adapt the contours. Because ultimately, subgingivally, the goal is isolation and adequate sealing and bonding. So the contour subgingivally, like I don't need a contact or anything. I just need it to be naturally emerging and have good emergence profile as it comes out of the tissue. And with these bands, the way they get positioned, because you're not using a wedge, and we've all seen that wedge technique where you place the wedge and now you've got this nice little step that literally on a radiograph looks like a wedge, and honestly becomes a food trap, a plaque trap. With this technique really elevates things and is more harmonious with the natural anatomy. And it's such a simple step, but yes, it does take an additional step. But this is one of those situations you slow down to speed up. You know, we talk about that a lot in 3D dentists, like slow down to speed up in your business, in your practice, with your team. But this is one of those critical situations. When you slow down, you will speed up because your dentistry, the quality of the dentistry, the efficiency, the effectiveness, the aesthetics, everything goes out like way better than it used to be. And more probably, you're not going to have the redos like you had before or the post-ops. So I love your copper technique because I think like that's a big component of your Instagram because you're kind of known as being that guy that does that really.
It was. Sometimes I bore myself like, am I posting another case like this? But, you know,
but people love it because we see it. And I think what's important is like what I love about the Instagram community is, there's a lot of the BS out there. But honestly, what it allows me to do is discover different ways of doing things and thinking differently. And
for sure,
that's one of the I love that restorative dentistry is we can see that we can do things differently. There are different techniques, different ways of doing that, you know, may work in my hands, they may not work in my hands. But the only way to do it is try, and it's a small community. So I love that concept of the margin elevation, the immediate dent sealing. You know, one of the terms that I keep hearing all the time with Biomimetic is the bondodontist. Like you guys, like the focus on the bond technique. And oh man, if I can give one piece of advice, in the restorative framework, is that know your bond protocols and know why you're bonding. Like so many of us just use materials because a rep says, this gives better bond strength. But do we really read how to use it? How do we need to condition or etch the dentin or the enamel? Is this what generation in bond is this? How does this work? Is this a two-step? Is there a primer? Is it total etch? Is it selective etch? And so many of these things impact the quality of our work that we may not realize for honestly a couple of years to come. And you talked about it being humbling when you start cutting off your own work and you start seeing some of these concepts. And so it really kind of becomes one of these pillars as we move forward. And what I love about the work that you do, Pete, specifically, is that it shows that you can run a great practice and create a culture around high quality dentistry that's quote unquote basic restorative. It's not the full arch implants. It's not the endo, all this. So one of the things I've got to ask, because I know every listener is thinking it because I'm thinking it, is that for me to do the quality of isolation, bonding, and aesthetics I feel, for me, this simple class 2 is going to take me 2 hours to do. So talk us through here, as we wrap things up, a little bit about the economics of like how your workflow, how that fits into how your team manages cases and how this impacts us in North America being generally a insurance-based practice. Like, you don't get paid for your time, you get paid for the composite class 2 restoration, regardless of how you did it or how well you did it. So walk us through a little bit of that.
Yeah, so, and that's one of the hardest things that you have to, not the hardest, but you have to be very purposeful about that in doing this type of dentistry. I was never the fastest dentist anyways. I'd always been using rubber dam, even before all this stuff. But yeah, you have to find that sweet spot. And so anytime I do a DME, a deep margin elevation, I always charge out the D2999 code. I always forget. I just say 29999. I mean, I forget, but it's non-specific restorative code, and it's not covered by insurance, and the patient is responsible for it. And so you can set that, and I think I have mine set at 200 right now. I probably should raise it, but that's in addition to, like I said, when I do, and that's kind of another reason why when I do a deep margin elevation, usually that tooth gets some sort of indirect restoration. I try to be conservative and save whatever cusps I can when I can, but I can't make it work and do this amazing direct. I mean, I'm capable of it. I'm not as good as so many people, but I can't do that. Keep the patient comfortable, do my hygiene exams, get paid insurance, what insurance pays, and not, I just can't win that way. And so usually I go indirect with those, and sometimes I've gotten flack for if someone has just root caries on a tooth way deep down. Sometimes I got to take the cusps down a little bit, and that tooth gets an overlay, which stinks, but then they didn't need endo. And I make it a point to celebrate that win. Kind of, I don't kind of talk myself up, but I say, hey, we if I would have done this 3 years ago, you would have needed a root canal and a crown, and then who knows what else years later. But so I always charge out the extra 2999 code and a buildup and the indirect code. And then if I have a tooth where I really can't justify going indirect, then I'll charge out the 299 code as well. But if it's really going to take a long time, I'll just up the fee on that, because and if they don't, I've actually never had someone not want to pay for it. I mean, I tell them that it's going to take the same amount of work as a crown, and that I have the ability to do it where they probably won't have any sensitivity or anything like that. And it took me a long time to really kind of know my worth and know that I need to charge for those things. And I take a ton of photos, and if a patient were to ever question why I did something, I would have the photography to show why. So,
and I love, I don't mean to interrupt you there. I love what you said, because you're hinting and talking about a topic that is near and dear to my heart, which is the power of why. And anybody who knows me knows I love Simon Sinek and all of those things. But one of the things, whether it's radiographs or anything, what I think is really important for listeners to understand is that, when patients understand the value and why treatment is needed, very few times do they really kick back. And there may be financial things, and that's different. That's a totally different topic. But when it comes down to it, if you have, patients should never be in this situation of be like, well, I go to the guy next door and his filling is, this class 2 is $280, $300. And ultimately what that tells us or me is that my patients didn't understand the true value of the service I was providing. And I think, Pete, one of the things you do really, really well, which is why this has worked well in your practice with these other codes and all of that, is that you and your team are very articulate about emphasizing the value of why you're doing the dentistry you do. And the why is not tied to you want to do these procedures. The why is tied into the survivability of their tooth, minimizing tooth removal, survivability of the pulp tissue to minimize future treatment that is going to cost more down the road. And honestly, making it very patient-centric is something that I think is critical for listeners to understand, that when you start doing this type of dentistry, you start expanding beyond the brick and mortar like box of drill and fill dentistry, because you're treating the person. And I think one of the takeaways I took away from biomimetic dentistry as a whole was that it is patient-centric. It is we are going to design the restorative plan designed around your specific needs of regarding how deep this caries is, what tooth structures are remaining, what restorative materials are available, what's in your mouth already, and coming up with a good treatment plan that truly is patient-specific. And when patients understand this, all of a sudden the cost isn't as big of a deal. Patients want to know that they're being taken care of at a high level. And then ultimately, what Pete has done very well is create a culture around that philosophy. And that for me is what's been awesome to see, is how you practice and you're doing these things, that I want to do in my practice, and I know I should be doing in my practice, but I think it inspires so many of us to see, hey, you can do these things. It can still be profitable. Your team's not going to throw fit because you need a rubber dam. You're doing high quality care, but ultimately, I think it's that long-term effect of like, I'm not doing all these damn redos, and patients are calling in for post-op sensitivity and adjustments and all this other stuff. So I got my hat's off to you, man. We've been talking a lot here, man. We could talk about this. We're going to have to do this.
I know we could talk about there's so many
topics here that I want to go. Like, you could do a whole thing on just air abrasion. But one of the things I like to do here is, like, you've had such a transformation in the last 5 years within your practice, and you're in my world, man, you and I are still relatively new grads, and no, we're not technically baby dentists.
We'd like to think so. Yeah,
we're still new, but we're not. If you were going back into your practice from day one, and you could tell yourself, hey, man, Pete, you gotta do this to help yourself get on a trajectory clinically, what is the one thing you would do?
I would say invest in myself sooner, because we spend so much money on dental school, but we kind of forget about it because it's monopoly money, it's loans, and you don't really think about that while you're in school, at least if you're like me. But once I did that and I invested in that mastership program, which was, double digits, I think it was like 10,000 at the time or something. That was a ton of money for me. Well, it's a ton of money for any of us. But after I did that, I wasn't afraid to consider a weekend course that costs $5,000, or a whole continuum, like a course. I haven't gone to, I've just done first week, but I never would have entertained that before investing in myself the first time. And I think that's the biggest thing for me. And it allowed me to meet different clinicians, and putting your work out there on Instagram, like we both do in our different ways, like connecting with other dentists who really give a rip. I mean, those things are super important, I think.
Amen, brother. Like, I think you nailed it. The power of education, the power of investing in yourself, your team, only just puts you to the next level. So Pete, man, I can't thank you enough for being here. For listeners,
thank you.
Pete, dude, how do people find you? You got to give, what's your Instagram handle? Because people need to follow you.
So it's Dr. Butkus, DRBUTKUSP. I was pretty proud of that when I thought of it. Butkus is my last name. P is my first initial. That's probably the easiest way to get a hold of me. I'm pretty responsive. Even if I don't post for a while, I always check my messages. So
you guys got to check him out. Pete's putting out some awesome content. If you're looking for more stuff, if you're looking to get, like Pete said, to get your feet off the ground, I got to give a plug to 3D, with regards to whether it's your business, your patients, your team, digital dentistry, airway, endo, you name it. It's such a great platform. So if you want to find out more about what we do, if you want to see some of my courses, check out 3d-dentist.com. Otherwise, give us a like, subscribe. We will check you back next week with our next guest. But Pete, man, thank you so much for being on, and we will check you guys later.
Yeah, thanks, Tim.
See ya.
If you enjoyed this episode, be sure to subscribe so you get notified when all the new content is released. And don't forget to rate, review, and share this podcast with all your friends and colleagues. For more information about all things happening within the 3D Dentist family, follow us at www.3d-dentist.com. Thanks for listening, and I hope you are leaving with new insights to help transform and level up your practice. Until next time, keep smiling.